things. We have Dr. Darrin, right? He's going to come up and speak about plantar fasciitis, Achilles tendinitis, essentially everything as it relates to the lower foot and ankle. And then we're going to, like I said, go out for a fun run and walk. We have Mizuno here. They are sponsoring this event, so they also have some shoe try-ons for you. If you try on one of their shoes and take it for the fun run and walk, they'll actually give you a little freebie plus a raffle ticket for some free swag after the run and walk. So without further ado, we have the director of the Columbus Marathon, the Cap City Half Marathon. He's also one of our 8-minute pace coaches, and he's a pacer for the Cliff Pace Bar team. Darrin, right?
Thank you. So we're trying to do this a little bit differently than what we've done in the past. Historically, we had kind of more of an educational seminar where we'd sit down for a couple hours or something like that, and in an auditorium type setting. And we wanted to try to break this down into more targeted pieces of information, things that might be more applicable to you. Perhaps some of you have suffered from one of these two conditions, so that we can kind of hit the important things and then kind of get out and have fun. And then throughout the season, I think there's about 16 of these different talks. You can pick and choose the ones that are kind of more applicable to you or things that you want to enjoy. So I want to keep this pretty casual. Now that we're not in a big auditorium with a couple hundred people around, I want to just kind of keep it casual. So if you guys have any questions as we do this, please, I want to make this almost more of a discussion type thing. But one correction to what Jeff said there, I'm not the race director for those events, I'm the method director for those events. And so with that, kind of work on securing the health and safety of all the participants, volunteers, spectators, stuff like that for those events. Something I've been doing for a while, something I'm really doing. Nice opportunity to kind of get into the community and see a lot of different people, as they're training for these events. I think I have one of the best jobs in the world, because as long as it's quiet, I'm sitting there at the finish line watching everybody come across after they just accomplished something they've been striving to do for quite a while, so it's a lot of fun. But wanted to talk briefly about plantar fasciitis and Achilles tendinitis. How many people have suffered from that in this room? Any of these? All right. And how many people think they're going to suffer from that? All right. About a third or a half of you should raise your hands right now, because unfortunately that's the case with some of these. But when we look at plantar fasciitis, lifetime incidence, about a 10% chance that, if there are 100 people here, 10 of us are going to suffer from that. Frequently, a third of the time, it's going to be bilateral, so it's not just going to be the one leg. Frequently, we're going to end up developing symptoms in the other leg. And looking at the running specific data, I know how many walkers do we have here? We have some walkers? Okay, good. And then rest, I assume, are runners or maybe not, just participants. But 4 to 22% when we look at the running literature. We don't have a lot of data yet when we look at the walking literature. And so some of the data and statistics I'm going to discuss are more running specific. And I don't in any way want to exclude walkers with that. But that's just what the data has been done on. And my experience in the office, when I'm looking at patients, is that the running and walking incidents and data, similar, it's going to be very similar. And so I don't find there's a lot of discrepancy there, but I do just have to clarify that most of this is running specific literature when we look at the science behind it. But of those, 4 to 22% of all runners are going to suffer from plantar fasciitis at some time in their running career. That's a pretty broad number, 4 or 22. I think, one data that really looked at a large study, one of the ones that the data that I probably quote the most in terms of injury incidents in runners, quoted as about 6.7% of running-related injuries are going to be plantar fasciitis. Younger athletes, 2.5% versus the aged athlete. I'm going to call it old. Let me say the aged athlete, 6.6%. So that's almost a threefold difference. So as we age, unfortunately, we know our risk for plantar fasciitis goes up. And that's also true for Achilles tendinitis as well. This is the beginning Saturday morning with quite a few people filling the stands for the first session of MIT. How many people are out there for MIT first? Okay, great. Good to see you guys out here. So, plantar fasciitis, hallmark symptom. The thing that I expect all the residents, all the medical students in our office to know is pain that first step in the morning. So you wake up in the morning, you put that first foot down, and it just hurts. And it takes a few minutes to get that leg going, just because it's just really painful. And so classically, it's going to be those first steps in the morning. Going to complain of heel pain and stiffness. Some people really find that they're able to run or walk through this. You know, once they get moving, we get some blood flowing to the area, increased elasticity, flexibility of that plantar fascia, and so sometimes people feel that they're better while they're exercising, but then they kind of pay for it later. So there's that, you know, post-exercise related discomfort that a lot of people get. So that's something that will kind of characterize plantar fasciitis, is that pain at the heel first thing in the morning, and then also maybe if you have a sitting job, a desk job, where you're sitting all day long, you get up, and you're going to re-experience that pain each time you get up. So in terms of, you know, the plantar fasciitis, you know, I think it's easy to just kind of understand what are we talking about here from an anatomy standpoint. And when we look at the foot and ankle, you have your long Achilles tendon here, which we'll talk about later. Then you have your big heel bone here, what we call the calcaneus, but the heel bone is fine. And then right here is a little point, a little kind of tuberosity of prominence on that heel bone, what we call the medial calcaneal tuberosity, because we like to put fancy names to bones. But really what it means is that's where the plantar fascia attaches to the heel bone. So it's that point right here. And then this is our plantar fascia. And you can see that a little bit better in this view, which is kind of a really thick, tough structure that runs from that heel all the way back and then extends all the way out through the arch of your foot. There's this real fibrous band that kind of runs right down through the middle, and then we kind of have the plantar apnerosis and this plantar fascia, and that's where people experience pain, you know, kind of right where this circle is, that area of pain. Some people will get a variant of this, which I sometimes see, which is more almost a strain. You know, maybe they're out there, and I don't know if people know that, you know, how far we've gone on the trail yet, but as you're coming from Antrim Lake, and then you have to make that 180, you know, almost 360-degree turn back on yourself down at the bottom. You know, one time I remember I did that, and that twist, I felt, oh, I think I just did something, right? The arch of my foot. It felt like I strained something. So some people can actually strain the plantar fascia, and that's a little different. That's kind of more pain out, more in the arch of the foot, as opposed to right at that heel, right at the attachment there. And when we look at exam, you know, when we're in the office, we're going to kind of confirm the diagnosis. It's going to be tenderness right at that spot. So usually people are like, how did you know it was right there? Well, I mean, it's the anatomy. We look for that medial calcaneal tuberosity, we put our thumb right on that spot, oh, that's the spot. And so that heel pain. When we look at it, you know, the other thing we're going to look at is your arch mechanics. And, you know, some people think, oh, I have flat feet, that's a bad thing. Oh, I have a high arch, that's a bad thing. Well, you're right. Both of those are bad when it comes to plantar fasciitis, because we find that people with low arches get this condition and people with high arches get this condition. So it doesn't necessarily seem that one is worse than the other. But one of the things that I find the most with this, and that's when we start talking about prevention and treatment strategies, is most people have some tightness in those calf and heel cord muscles. And that's an important thing. It's something that we can usually elicit on examination. And where are we here? That looks like we're right at the end of the MIT trail. They won't take your bike path right at the turnaround by the gazebo there. So some shots along the way here. In terms of treatment strategies, there are three things I think about when I talk to all patients about with plantar fasciitis. The first thing I think about is support, supporting that arch. The more we support that arch, when you put weight down on your foot, you know, the concept is every time I put weight down on my foot, that plantar fascia is literally trying to pull off where it attaches onto the bone. So every foot strike, I'm trying to pull that muscle off of the bone. And so if I can support that arch a little bit better, I can take some of that tension off of that painful spot. So one of the things that we look at a lot is supporting the arch. We can do that in a lot of different ways. We see a whole wall of arch supports over there. Recommend that a lot. Sometimes it's as simple as putting an arch support in your shoe. You know, coming in and talking with somebody here, working with one of the shoe specialists, or Lauren, who's our athletic trainer who's working here, having them look at your foot mechanics and see if it might be as simple as just kind of working with some arch supports. Sometimes I'll have people go to physical therapy or work with a physical therapist. And what we'll ask them to do is a trial of arch taping. And that's a special tape job. A little different than KT taping and rock tape. It's more a special taping job. They put some spray on, and it stays on for 2 or 3 days. And a lot of people say that was magical. You know, what did you do? In my world, that means you probably benefit from more custom orthotic. where we take a mold of your foot and then we slip that into your shoes to help support that arch. And for a lot of people, that can be pretty curative for plantar fasciitis. So you'll hear a lot of people say it was the orthotics that did it for me. It's variable. Maybe it was the arch safety, maybe it was the superfeet. You know, it's variable. That's the other thing you'll find with plantar fasciitis. Anybody who suffered from plantar fasciitis, they probably had 15 people tell them what it was that got it better. And it's variable. And what I always find is it's trying to find that thing that's right for you. There are a lot of different things that we can try, but that's definitely one, arch support. The second thing I think about with plantar fasciitis, so first, arch support. Second is flexibility. And I mentioned that tightness through our calf and our heel cords. If we can get some more flexibility through there, when we put weight down on our foot, it's more flexible. It's not going to pull as much, and it's not going to be as painful. So there are definitely some very specific stretching exercises, working our calves, our heel cord, and our plantar fascia that we want to get people on. So stretching. And along that line, how many people have heard of night splints? Okay. How many people have used night splints? And how many people have started with night splints and found them laying on the floor the next morning? That's unfortunately, my experience a lot of times with night splints is because they're not the most comfortable thing, but basically it's a fancy sock that you wear, and it has a piece of string that goes from here to here. Someone paid millions of dollars for inventing this thing, Mr. Strasberg. And so it works well for some people. And what that does is it helps to keep some flexibility through the night, you know, pulls that heel up so they get some flexibility through the calves. Those first steps out of bed aren't as painful, helps to alleviate some of the tension in the area. So night splints can definitely help. Sometimes I think just as effective is to take a bath towel and keep a bath towel by your bed. And when you wake up in the morning, before you take those steps out of bed, throw that towel around your toes and pull back. Hold it that way for about 15, 20 seconds, then relax. Do it 3 or 4 times, and then usually those first steps out of bed aren't going to be as painful. So that's the bath towel trick. And then the third thing I think about is blood flow. Historically, and that's why we call it plantar fasciitis, some people are arguing we should change the name. Historically, we've always thought plantar fasciitis was an inflammatory condition. It was all about inflammation. And so what they did is they took volunteers who suffer from chronic plantar fasciitis and said, can we take a biopsy of your plantar fascia? And everybody said, sure. But what they did is they looked at that tissue underneath the microscope, and they found there really wasn't that much inflammation present. And it was really just tissue that wasn't getting a lot of oxygen, it wasn't getting a lot of blood flow, it wasn't receiving the nutrients it needs to heal. And so the other thing I think about is blood flow. And that's where, again, physical therapy can sometimes be helpful because there's some different modalities that we can do, some ultrasound, iontophoresis, different things that help to improve blood flow to the area and deliver those nutrients and oxygen and things that the tissue needs to heal. So blood flow is the third thing I think about. And then, then the other things. There are a lot of different things that we can try. Another thing that I do is a technique called ART, which is active release technique. Deep tissue massage technique. Doesn't feel very comfortable while we do it, but it tries to break down some of that scar tissue, get some improved flexibility through that plantar fascia. And for some people, it can be pretty helpful. Plus minus injections. A lot of people say, well, an injection is what got it better for me. I'm not the biggest injection fan for this. Some studies have shown there's a risk of a rupture of your plantar fascia, about 3 to 5% with each injection. And then you got a tough problem if we do injections. So I don't love injections. The second downside to injections are steroids, which is what we're injecting, because they're anti-inflammatory agents. They emulsify fat. What I mean by that is they thin the fat down. And that sounds like a good thing. A lot of people will be signing up for that one, but not in your heel. We have a nice fat pad there that helps to cushion and shock absorb when our foot strikes the ground. And if we eliminate that fat pad, we may be, robbing Peter to pay Paul later. This is something that might catch up with us later. So I'm not a huge injection fan, but it doesn't mean I don't do them. And they have their role, but I don't like repeated injections, multiple injections, but maybe we give it one shot and see, especially if we've really struggled with this. We've tried all the other things, and it hasn't gotten better. That may be something else to try. Other things you can hear about acupuncture. I have some partners with acupuncture, and they treat plantar fasciitis quite a bit with that. That can be successful. And then there are real resistant cases. And if you get on Google and you Google, plantar fasciitis, you can hear some bad stories. People who struggle with this for a long time. There are some surgical fixes for this. And they have some pretty decent success rates. But you're laid up for a little while afterwards. And it doesn't always work, but for a lot of people they can find some success with that. So that would be another option there. Starting line at Columbus Marathon. That looks like a big city marathon, doesn't it? 18,000 people lined up next to you. How many people do it, Columbus? Half or full? All right, good. Good show of hands in. All right. Well, what about prevention? Some studies are showing, one thing I didn't talk about the epidemiology, body weight. The more weight we carry, the more likely we are to get plantar fasciitis. So a lot of people would suggest from a prevention strategy is to maintain a healthy body weight. And that could be a prevention strategy. Another thing in the literature when we look at the running, and again, not necessarily walking specific, but I think it applies, there is an incidence of increase of plantar fasciitis in people making big jumps in their training. So maybe they're running 10, 20 miles a week, and also they jump to 40 or 50 miles per week, or they haven't been exercising, they jump in to some high miles. So we want to have gradual increases, and that's one of the things why I've been running with MIT now for almost 12 years because I like the program. I think it's a very well thought out program, trying to make sure we don't have those big increases and be very gradual in bumping those violations. Other thing is proper shoe fit, making sure your arch is well supported, and that's what everybody here does. I always say, running shoes are an investment in remaining injury-free and not necessarily an expense. So make sure you have them fitted, have people look at your shoes, look at your feet, and make sure you're in the right type of shoe. Along that line, let's just talk briefly about running shoes. I'd be remiss if we didn't discuss that in this setting. But I want to talk briefly about life expectancy and then proper fit. When we look at life expectancy, this is where a lot of the literature comes from when they ask, how often should I change my shoes? Fair question. A lot of people say, well, somewhere between 350 and 500 miles. And it's going to vary a little bit based off of your body type and your wear pattern. But the reason for that was this study where they looked at wear patterns and shock absorption. When your foot strikes the ground, every time your foot strikes the ground, 4 to 5 times your body weight has to be absorbed by the body. And your shoes are your first line of defense. At around 250 miles, we lose 40% of that shock absorbing capacity. And so if your shoes aren't doing it, guess what is doing it? Your shins, your knees, your hips, your joints. So that's the reason why it's important to replace our shoes regularly. And it's also important that we get fitted properly. If you just look at kind of footprints in a mold or sand, when we talk about pronation and underpronation, what we're talking about is that a person who's kind of walking on the inside of their foot where their arch is collapsing. That's an overpronator versus an underpronator who's kind of walking that very high arch and not really collapsing at all. Based off of that, there's a shoe for you. This is a neutral cushion shoe, more designed for that higher arch foot where this is real cushiony and soft, as opposed to someone who pronates and needs a stability shoe. This is a much higher density structure, so it won't allow my foot to collapse in. It brings the ground up to my arch to give it some more stability. And then for someone who needs extra stability, we have the motion control shoe. So that's kind of shoes. I mentioned the cushion insoles. These are the super feet. Not only do I think they can help support that arch for having some plantar fascia symptoms, but some recent literature showing that just the over-the-counter insert seen over there can help to decrease our risk for stress injuries. So perhaps if you've had some stress fractures in the past, not a bad investment to slip those in your shoes just to make sure we're decreasing that risk. 15% of all running injuries are stress fractures. So it's something, unfortunately, we sometimes see. So let's talk about plantar fasciitis. Questions before we move on? Yeah?
Are there any studies done on foot strike versus injury? Is it?
Yeah, great question. There's a big movement right now in terms of looking at foot strike with the big shift of there's a big swing saying everyone should be doing mid-foot type strike, the minimalist type movement. I think that pendulum's swinging back pretty quickly the other way, and not to say that midfoot is bad, but that maybe heel strike isn't as evil as everybody thought it was. And I think we still need some more studies. Specific to foot strike and injury patterns with plantar fasciitis, I haven't seen anything yet. But intuitively, I would think that more that that midfoot strike, I see a lot more Achilles and calf issues because what we're doing when I heel strike, I'm using the shoe to cushion. When I strike here, now I'm using my calf and my Achilles and some of my plantar fascia to absorb those forces. And so intuitively, I would think that we might see some increased risk in those. I know we see Achilles and calf injuries more in people making that transition. I haven't necessarily seen something specific to plantar fascia, but I can't help but expect that. Have you seen anything on that, Angelo? Angelo is one of our physical therapists from Ohio.
Not in regards to I think even a heel strike versus midfoot, it's kind of where your body, where your foot's at as it's coming out of the knee. So if you're hitting more, your heel strike, you're hitting the check mark versus kind of where it's at in relation to your hips. And sequentially, I have to change what are the hips doing. So what's going on with hips, force stability-wise, flexibility-wise, strength stability-wise, it's causing you to hit that way where you really load versus coming out heavy on the heel on a heavy versus still kind of hitting midfoot heel kind of underneath. There is some correlation with hip weakness and some other things. So it's not really the formation, it's really kind of how you control the formation. You're kind of reaching out first toe for the ground and have bigger faster distance.
Any other questions? Plantar fasciitis.
Does it ever extend up to like the ball of your foot, or is that a different?
Yeah, I do find that definitely that can happen. Especially the more stress you put on it, you can start to see more involvement out into the plantar fascial muscle itself. And that's kind of what I alluded to. Sometimes I find that the people who don't really have the classic plantar fasciitis, it's more that plantar fascial strain. And that's where we need to look at a lot of kind of what Andrew was looking at and talking about there is, what else is going on biomechanically to cause that extra stress there.
When you wear the arch, when you have plantar fasciitis, you put the arch, doesn't the weight go on some other part of your foot?
What's that?
I had plantar fasciitis a couple of years ago, and I used to use those inserts. And then what I found was the weight shifted from the heel here to my knee, or I'm not sure. So it kind of transfers.
Sure. Well, definitely anytime you make a change in terms of biomechanics and putting in arch support or orthotic in can definitely do that. It needs, and that's where we're kind of working with an expert to try to get you in the right type of one based off of your foot mechanic. Because if we overcorrect, you're right. Sometimes we can end up with some issues further up the kinetic chain. And so it's making sure it's it's been fitted properly. And sometimes even we do our best to, okay, now we need to make a small adjustment. It's a little trial and error. Any other questions? Yes?
For people who have it already, is there a higher risk of recurrence?
Yeah, so if you've had plantar fasciitis before, there's a higher risk of recurrence. And I haven't seen that specific statistic, but I have seen, and you'll see in the Achilles literature, that other leg, you are at increased risk in the next, like in Achilles literature, is 8 years. You have like a 30% there. Here it is, 41% chance you're going to get in that other leg. So I haven't seen specific to getting recurrence in the same foot, but you are at increased risk for getting it in the other foot. Anything else on plantar fasciitis?
Is it okay to keep running?
Good question. And you'll get a lot of different opinions on that. My usual strategy when it comes to plantar fasciitis and even Achilles tendinitis is let pain be your guide. And there are a lot of people who say, I feel better when I'm running. It's actually the only time I feel good. And I said, go run. As long as you aren't paying for it for like 2 or 3 days afterwards where you can't walk, and as long as you aren't limping. That's my cardinal rule. If it's affecting your gait, you need to back off. But if you're feeling better while you're running, I'm okay with that. As long as we're not just putting our head in the sand and ignoring it and saying, well, I said I can run. As long as we're doing some things to fix it and direct some therapy out of it. Anything else? All right, good. So let's talk about Achilles tendinitis. How many people have Achilles? I've had it myself. It's a tough one. There are different types of Achilles issues. There's Achilles tendinopathy. Kind of gotten away from the word tendinitis. You don't see the itis there for the very same reason I talked about the plantar fasciitis. When we've done studies, there isn't a lot of inflammation present. Sometimes acutely there is, but that resolves. It's more just the tendinous area. Just kind of break it down. I mean, fibrotic and not a lot of oxygen and some fibrosis occurring. And that's what we call tendinopathy or tendinosis. So 67% of the time, it's the classic Achilles, right there. 23% of the time, it's insertional. So it's right where it attaches down on the heel bone itself. And then 10% are just kind of others, or some other things that you can sometimes see. 8 times more common among runners. Again, I don't have the walking literature, but in the running literature, we know that if you're a runner, you're 8 times more likely to get an Achilles issue. And if you develop Achilles issues, this was, maybe I had it on my left, within a year I had it in my right. And then, did therapy, strengthening, and I haven't had any issues since. But definitely that contralateral leg can be affected. And they've shown in the elite level runner, I know we have a few in the room, but the elite level runner, it's upwards of 8 to 9% annual incidence rates of Achilles tendonitis. So pretty high incidence. You know, if you think about one injury accounting for 10% of participants in a high-level runner. Symptoms, it's going to be similar, but now instead of it being on the undersurface, this side, it's going to be the heel back here, right along that Achilles tendon. Stiffness will often be worse in the morning, but how do we sleep? We sleep most often like this with our toes pointing down. No one kind of sleeps like this. You sleep like that, what's happening? My Achilles tendon is retracting, my calf muscle is shortened, and now I go take a step out of bed and I'm asking it to lengthen, and my body doesn't like that. My Achilles tendon doesn't like that. So it's stiffer, it's going to be more painful in the morning. And frequently, similar to plantar fasciitis, this is one where you can, early on, not always, but early on you can usually continue getting some miles in, but oftentimes you pay for it. Where it really gets inflamed afterwards and you get a lot of discomfort afterwards. So where's after that? This is Chicago Marathon starting line, 42,000 of your closest friends. It's an amazing experience. Anybody done Chicago? It's a great one. It's a lot of fun. One year I was training for Chicago, using it as like my goal race, and kept looking everywhere for a topographic map. And I had to plan my whole race out. They kept saying, it's flat, it's flat. I go, well, where's the map? Where's the map? And I kept getting transferred. Finally I got to Gary Kinhowski, who's the race director. He said, Darrin, there's 17 feet going over the last bridge. That's it. So it is truly one of the fastest marathons in the world. They talking with the race directors one day at a little patio lunch. They were talking about what happened in the development of why Chicago and New York just took off. And they were trying to outdo each other. So Chicago said, we have to have all the elites here, have the best in our race will grow. So they kept growing their prize purse, more and more money, more and more money. And then they both said, this isn't sustainable, we got to do something. So the Chicago people said, we need to build the fastest course in the world and everybody will come, and that's kind of what they did. At one point, I think it was 11 of the 15 fastest times in the world were on Chicago. So it's a pretty fast course. Looks familiar? Same picture we saw earlier. So here's our Achilles tendon. You have your two calf muscles, I think I show here. Yeah, so you have your gastrocnemius, which is kind of your ball muscle, and then you have your flatter soleus muscle. Those two muscles kind of fuse down and then form that Achilles tendon that attaches onto the heel bone. So that's kind of what we see there. And this is kind of that area, which is what I consider called a watershed area. And so what happens is we get some nice blood flow coming this way, some nice blood flow coming this way, and we have this area right in here that just doesn't get great blood supply. And so that's usually the area where people get some issues. There's usually going to be tenderness along the tendon, so you can kind of squeeze that tendon, like, oh, that's the spot. Sometimes there'll be a little bump, nodule, kind of be a little squishy there, not look like the other side. Oftentimes you're going to have that same decreased calf and heel cord flexibility. Treatment, going to look pretty similar. Ice is a big one. I'm a big ice fan for this because I think acutely there is some inflammation present. When we go out and we stress it, there's some inflammation present. So getting some ice on it afterwards can be very helpful. Again, we're going to have some similar stuff with flexibility, stretching. Some people do night splints with this. Again, I'm plus minus on that. I'm kind of focused on my calf and my heel cord stretching. Strengthening is really one of the big things on this, and a lot of the literature has been pretty consistent on it, and it's a little bit of different strengthening. A lot of people, when you talk about strengthening, if I'm doing a biceps, we're talking about, I'm lifting up and I'm just dropping the bar down. I'm lifting up and I'm dropping my bar down. When we're talking about eccentric strengthening, it's just the opposite. I'm bringing the bar up and I'm taking it down really, really slow, very, very controlled. So controlled lengthening of the muscle. And that's what's been shown to be in the literature the most effective for Achilles tendonitis. And so, what I always suggest to people is they get on the edge of a step, and I call it, I'm probably going to fall off here, my up together, down slow. So I come up together, and with one leg I take it down really, really slow. And then up together, and then down really, really slow. And it's that down slow that really makes the difference. And we always suggest, much better to do 10 of those with really good, really controlled form than trying to bang out 30 really fast. It's very controlled. This is one where technique means everything, that mechanical advantage there. Relative reps. So I usually say the same thing. As long as you aren't limping, we're probably okay to run with this. One study looking at runners found 70% were back to their pre-activity level within 3 months. It's going to be a little bit of a layoff. can get to it, sometimes I think the better we are at getting people better. Same thing with plantar fasciitis. I think a lot of the bad stories come when people just kind of put their head in the sand and just keep on going, and not addressing some of the biomechanical things that we need to address through therapy. Prevention are going to be very similar. Gradual increases in training. Don't bump up real quick. Oftentimes we talk about frequency, duration, and intensity. That's how you want to increase. You don't want in the same day, the next day I should say, go further, longer, and faster. We want to be very gradual with those increases. Get how often you're going to run, then how far you're going to run. The last thing you want to focus on is intensity. Caution with hill training. This is very common when we're doing hills. Lots of hill repeats. That's what kind of when it caught up with me. I was training hard for a race, doing a lot of hill repeats, and that's when that it caught up with me. Again, proper shoe fit, making sure we've been properly fitted, and it can be effective for a prevention strategy. This was Chicago Marathon 2007. When it got too hot, they canceled the race in the middle of the race. And they opened up all the fire hydrants and tried to cool everybody down. Put a big sign up in the middle of the course, race over, please walk back to the park. That's one thing you never want to see. So that's it. We got to run, so I don't want to go too long. More again, want to keep this kind of just interactive. What questions do we have on Achilles tendinosis? Yes?
What's good for people who've never had it before, like prevention?
Yeah, I would say, on the MIT, are you an MIT? Good. And on MIT website, there's a runner and walker 10, which has some good exercises to do. And that, a lot of those are focused on our calf, heel cords, hip strengthening, as Angela was referring to, and just doing some good stretching, maintaining flexibility, and then proper shoes. The other thing that I sometimes recommend is not necessarily prevention strategy, but if you're having some issues, you've had some issues in the past, compression socks. There's some good literature out there showing compression socks, which, where are they? Oh, they're in this room, right? Oh, okay. They're right around here. But compression socks look like, we're back in the 80s, come all the way up to the top, very fashionable, but they provide some nice compression through your calf and your heel cords. And very good literature out there showing that they can improve your performance. So take injury out of it, just I want to get faster, compression socks have been shown to benefit performance. And then if you have some issues in your calf heel cord area, I find that it can help to keep that muscle warm and can help to eliminate some symptoms. That might be one thing that I would look at. And the biggest thing I think is going to be being cautious with your increases in mileage, cautious with your speed workouts, make sure they're well thought out, laid out well through a coach or a training plan. Maintain that flexibility, make sure you've been fitted for running shoes, and keep your fingers crossed. Yep. One more question, and I think we got to run.
Literally.
What's that? Heel cups. Yeah, heel cups, definitely. I find that they can buy some time, and so when you're acutely suffering from it, I think it can be effective. I don't necessarily recommend it for a prevention strategy, but it can buy some time. So if acutely you're having it, you're getting close to a race, putting a little bit of heel cup in, and what that does is it lifts up my heel and it's taking a little bit of pressure off of that tendon. So we just put these small, not huge, we're not talking this much, just a little bit, these felt pads that we can slip inside the heel, and for some people that can be effective. The problem with it, the time I think of them is, 2 weeks out from a race, so we got to try to get you through what we do, maybe a heel cup. I hate putting new things in shoes and saying, yeah, go see that how the 26 miles goes. But if we can test it out a little bit, that might be okay.
When you're over it,
I think